Thank you so much for joining us today in Rappler Talk. I'm so looking forward to speaking with two experts who I hope will help us make sense of the world we're living in today. You will see Erica Legara. She is one of the Philippines' top complex scientists, and she is the chair of the Aboitis Chair in Data Science at the Asian Institute of Management. And then, of course, a familiar face, uh, former Secretary of Health, Manuel Dairit. He was in charge of the Philippines reaction from 2002 to 2003 to the very first, the SARS 1, if this pandemic is SARS 2. Welcome both of you to Rappler Talk.
Hello, Maria.
Good morning,
Um,
Maria.
Good morning. Erica, I'm going to throw the first question at you
Okay.
because you've been looking at data forever and how complex systems revolve around this. And this is one of those wicked problems. What kind of data are you monitoring today?
So right now we are really very limited to what the government is releasing out there. This means the number of tests conducted, which is given on a daily basis, but we don't have historical data on that one. We also have the confirmed cases. So I just want to emphasize that this is confirmed and detected. This is not the total number of cases, and of course the deaths and the recovered cases. So these are the kind of information that are that's available to us at the moment, and this is the data that we are currently playing with.
And what meaning do you get out of all of that data? What is the nugget that you're looking for? Why
So
should we monitor those?
it's the same as what we are seeing globally. Of course, the growth trends, which is the the most, in my opinion, Sec Diary, please feel free to correct me, the most important at the moment in terms of truly understanding the trajectory of this epidemic, the scale, what is the potential of this epidemic. And we can see that from the growth trends of our infected cases. Unfortunately, right now we only know the reported ones. So, so that is an important indicator. And right now, Dr. Chris Monterola, who is my colleague, and I are trying to develop a new way to instantaneously, with this information, with this limited information, to instantaneously track whether or not certain measures are working, given the current situation.
Many other scientists around the world have talked about the exponential growth of this
Correct.
curve, right? And how globally we're still not at a point where it has peaked. Is that correct?
We're not seeing that yet, unfortunately, Maria, at the moment. And most countries are not yet seeing the peak, unfortunately. But we can take a hint from China and South Korea. For example, if you look at China and South Korea, it takes about 2 weeks to a month before you see the peak. But one of the things that we also need to understand is the measures that they took for them to reach this peak at a much shorter timeline and then flattened out about 1 to 2 months later. But for the Philippines, right now we're really not seeing it yet, and we need more data. When I say more data, we need more tests. Imagine this. I'm pretty sure a lot of us have read Thomas poem, right?
He's also published on Rappler.
Oh, okay, cool, cool. Thomas gave this example, like if you have one death today, right? You can, and if the mortality rate conservatively, Maria, is at, let's say, 1%, it means that this person who died today was infected maybe, let's just say 20 days ago or 2 weeks, right? 2 weeks ago. And 1% mortality rate, which is conservative, means that there were probably 100 infected cases at that time, 14 days ago. So what we observed was that every 2 days, 2 to 3 days, that's the doubling time. Okay, the doubling time of number of infected cases. It means that if you have 100 cases, Okay. 2 days from that day, you'll have 200, right? And then 2 days after, you'll have 400. The thing is, we're only testing below 200, right? So how will you be able to capture that growth if we're very much limited to the number of tests that we're conducting? So no matter how good we are in tracing the trend, which is what we see, the J curve or the hockey stick that they're talking about, if we're just gonna look at the detected in the Philippines, given the rate by which we are testing individuals, I think we are in big trouble.
Thanks, Erica. Secretary Dairit, Dr. Dairit, so former health secretary who led the charge against SARS from 2002 to 2003. I've heard you talk about how different this is today, and you're right that this scale, we've never dealt with anything like this. What data would you need in order to get a sense of where we are today?
What we actually look for in order to understand how the epidemic is going is what they call the reproductive rate. The reproductive
Contagion.
rate is
Yeah.
the number, right? The number of cases that one infected case might infect.
Mhm.
And I know, based on talking to some of the people who were involved with interagency, that they actually postulated a reproductive rate of 4,
Wow.
which means that they are looking at a surge of cases to the level of about 75,000.
Wow.
The other reproductive rate that they considered was actually 1.4, which meant a surge of cases to 20,000. I think they used these reproductive rates of 1.4 and 4 based on the data that they got from China.
Mhm.
So I think that that's one of the things that we need to understand. And the way you compute for reproductive rate is actually to collect the data, which Erica has mentioned, and then actually plug them into mathematical models and
Correct.
try to compute what the actual reproductive rate might be. Okay, so that's one of the things that would be done. Now, I've read some of the mathematical projections that are online, and the other, you might say, statistic that would be of interest is the doubling time. And
Yes.
for example, in one of these models that I saw, I think it was Our World in Data, that was the source. The doubling time for the Philippines was 5 days. Compare
Wow.
that to Singapore, which had a doubling time of 10 days, and compare that to Italy, which had a doubling time of 2 days. So these are the statistics that you would be looking at in order to understand how this epidemic was moving. Now,
So
because we're not doing, okay, I'll
go
stop
no,
there.
please go ahead. Please go
Okay,
ahead. You were saying because we're not doing
yes,
contact
because
tracing, I'm
we're
gonna
not
say.
doing enough testing.
Yeah.
You see, when you do the tests, you actually try to cover as many of the population, as many of the general population who are out there, who think that they may have encountered somebody who was infected. So
Yes.
you're just covering your population with tests. And that, in a sense, gives you what epidemiologists would call some prevalence information of
Mhm.
what is the level of infection in your population. By doing that, you can then have your actual data from
Mhm.
these tests, and you could compare that to all of the mathematical projections that are being created. Because these mathematical projections still rely on assumptions
Yes.
about your reproductive rate,
Yes.
about your doubling times, and so on and so forth. This is the way you would try to map the progress of your epidemic.
One of the things I've heard you talk about in the Philippines, and I'll bring some of the data you mentioned into the real world. 5 days doubling time in the Philippines, 10 days in Singapore, 2 days in Italy, although that also seems to have changed now, right? Um, from Singapore to the Philippines? Is that because of the measures that are put in place, or also because of the level of poverty?
I would say Singapore had a doubling time of 2 days because their interventions kicked in early and they were actually able to suppress the infection. In Italy, I suspect what happened there was because it was tourist season, there was just so many people that came in infected and it just snowballed. And therefore, with that mass, that cumulative mass of infected, they then just got their epidemic going very, very fast.
Erica, please feel free to ask questions if you want to, right?
Sure.
Uh, in terms of the response rate of getting all of this data out, why? I guess I'm wondering why we're not talking about data of health and warning our people. Is this, you managed a crisis like this before? What kind of communications can we do with this kind of data?
I think they're trying, the government is trying to balance, on one hand, giving data, and the other, trying to prevent panic. And so they're veering away from large numbers, of
But both
saying these are the large numbers because of the possibility of these being misinterpreted. And so it's
both of these,
piecemeal. It's an approach of piecemeal. Yeah.
which doesn't give us, well, all right, let me, I'm trying to be constructive in everything.
Yes.
In
But what I can say is,
Go ahead.
yeah. But what I can say is, if you looked at the figures that they announce on a daily basis, just fact that that data is the picture 7 to 10 days ago. So if we are now upwards of 462 or
700.
500 plus,
Mhm.
are we at 700 already?
Yeah,
So that was the
707.
figure 10 days ago. But really, what you also have to consider there is the rate at which they are now doing testing, because their capacity has probably doubled. A week ago, there was only one lab that was doing the testing, which was RITM. Now, I understand it, there are now 3 or 4 labs that are doing the testing, and they're probably clearing the backlog, which was at the level of about 1,000 samples. So you are seeing now a picture of 10 days ago plus the backlog,
Mhm.
depending on how long that backlog actually was. And therefore, you then compute your projections and say maybe it's doubled or it's tripled, and using the the, the factor that was actually recommended by Thomas, either do it times 4 or times 8.
Yeah.
That there were doubling times in that period of 7 to 10 days.
Yes.
Okay, if it was a 10-day period, then you say we've doubled two to the 4 times. Okay, so what are our number of deaths? Our number of deaths is now how many?
It's at 45.
Okay, 45 times 100. That's 4,500
That was 10 days.
times 4. Okay, times 4. And that will give you, we're close to 20,000 cases
Yeah, a little more than.
of-
Which is Maria.
in the population.
Which is Maria. Our initial estimate. Our initial estimate was at 26,000, and Secretary Dr. Dairit is actually correct because when we first released it, if you remember, Maria, a lot of people were like, "Oh, you're causing undue panic," and but that was what we saw in the trend, and we felt that one of the things that I found lacking was that information, right? Was that we are lucky because we're always online, we always get to read all of this stuff, but how about the rest of the Filipino people? They don't have any idea, right? So and then what they're seeing is that the number of confirmed cases are increasing only by the hundreds, but
Yes.
what we know is that these are just the detected. That
Yes.
for all we know, maybe we're now in the tens of thousands. Again, it's a speculation, but if you will look at data from other countries, that is what the dynamics is telling us. It's just that we don't have that much data. So one of the suggestions of my brother, who is based in Cagayan de Oro, is to have like billboards I know it will cause panic, but I think we really have to inform the people because as early as March 15, March 16, I wasn't seeing information on the Philippines that's data driven. So
Yes.
that's why I'm very grateful to Rappler for releasing different models so that people can start talking about it. I know that the numbers are scary. In fact, other agencies are giving much higher numbers, and some people just cannot imagine this big of a number, and then they're like panicking. But we should panic.
Actually, that's the reason we published your model, Erica, because it was one of the first ones. And then a day later, WHO and the DOH also published a number without any of the assumptions, which was from 26,000 was your model. Theirs was at 80,000, right? So again, well, as a communications person, I think transparency becomes critical in a time of crisis so that you can pull your people together. Um, uh, Dr. Dairit, you talked a lot about intensive care facilities. In fact, you were the first person I heard who talked about the fact that private hospitals a week and a half ago were managing 52% of the COVID-19, and yet the government response doesn't take that into account. And then you also talked about intensive care facilities and ventilators, one of the few again. And please remind us, why is that number critical once you have the other numbers we talked about?
I'm told that there's a figure that's been released that there are about 1,500 ventilators in the country at the moment. But they had a computation that the number of serious cases could actually be upwards of 3,500. So if you're thinking just by averages, we know that we don't have enough ventilators to treat all of these patients if they came in all at the same time. So these are some of the figures that are very useful that will drive our managers, our hospital administrators, and government to make sure that the resources are there to address these concerns.
And the basic assumption in this, in managing for the number of ventilators, is that you don't want to overwhelm the healthcare system to the point that the people who desperately need that ventilator cannot, and that means they will die. Correct?
Yes, that is correct.
In the absence of that 1,500 ventilators, the government has actually talked about creating COVID-19 facilities. Um, what measures? What measures, I guess, do you think will be effective in dealing with the fact that just based on the numbers, we know our healthcare system, our intensive care system, and our healthcare system will be inundated?
The whole idea for creating COVID-19 dedicated hospitals is to make sure that, one, the hospitals that have to deal with a lot of cases as well that are non-COVID are able to do that. And what has been happening now is many of the hospitals that admit COVID patients are just getting swamped. And because of the nature of the contagion, they just have to close down some of their facilities if they're contaminated. And therefore, the strategy is to create these COVID dedicated hospitals, put the COVID cases there who need critical care, and hopefully release the other hospitals to take care of non-COVID concerns, which actually happen every day. Imagine the
Yes.
number of women that need to deliver, that need to go to hospital, and so on and so forth. That might be put on hold and be jeopardized because of COVID-19.
Um, I know I promised you both only 20 minutes. We're at 19. So why don't I ask you, Secretary Derrit, again, there are many different ways that countries around the world have been dealing with the crisis. Uh, can you describe the top three?
Well, the top three would be one where they had a multi-layer approach. When I explain it, I say they had an approach that reached people and families in their households, gave them information there, and explained what behavior they needed to do. And then they had their primary care layer, and these are the primary physicians in the community. And then they, and were able to manage it so that they didn't swamp their hospitals. And when their hospitals actually saw patients, they were able to treat them very well. No deaths in Singapore. I guess you'd put South Korea as another model for this. And essentially, what they deployed was really widespread testing in their community, really to infect some people who was positive, and to eventually get these people to quarantine themselves and isolate themselves and prevent the infection from spreading. And therefore, the reproductive rate went down very low as a result of this strategy. Okay? And I guess the third example would be China itself, that did all of these draconian measures, including shutdown and really massive suppression of their population so that the virus wouldn't spread. So these three examples are examples that we can look up to and emulate or borrow from uh, for the situation that we have.
Our response to this now as a nation seems to be a combination of all of that. I mean, in a way, it is good to put a lockdown in place, but the chaos of the way it was executed also meant a lot of people with the virus left Metro Manila in the 2 days after March 12th, right? Um, uh, Erica, let me ask you, looking at the numbers and in a complex system with these kinds of exponential growth, what do you think are the possible mitigating factors that could walk in to try to find the the turn of the curve?
It's really like you already articulated it. It's about delaying, to be honest, the number of infections going to the hospitals. So it's about flattening the curve, and it's the social distancing measure, but done should be done in a proper way. One of the things that's really bothering me at the moment, Maria and Sec Dr. Dairit, is that when it was announced on the 15th that we're gonna have a quarantine, and they said they're gonna lift this on the 12th of April. My question was, what's the basis of that? Would we be ready by then, right? If I'm willing to stay longer, to be honest, but we also need to make sure that we are balancing things like physical health, right? The mental well-being of individuals, and also not a lot of people appreciate this aspect, the economy, right?
Yes.
But so what is the right date? Without data, without data-driven decision-making process, things could get even worse for us. So yes, we should flatten the curve, but for how long? They say that 1 to 2 weeks should be enough, but we need to see that working. And the only way for us to really see that working is if we have enough data to give a more honest assessment, to have a baseline that such measures are truly working.
Erica, with that baseline, do you think that you could factor in the rate of poverty in the Philippines? I mean, could we do some kind of an urban, like the areas where there are people in close quarters to be able to predict where
Uh,
testing should go or
Yes,
isolation?
that's a very good question, Maria. In fact, the data that I was just talking about is just the infected, confirmed. That's the cases. But another data that would be useful, like Dr. David said earlier, was the capacity. And you're right, we can compare that with the urbanization of a certain locality, right? So that is a more data-driven way. In fact, we're talking to one international organization at the moment, and then they're asking us if we have a wish list of data coming from the businesses, what would it be? And I said mobility data. We need
Yes,
to have mobility data because that will really give us, because we know that people moved out of Metro Manila. Where did they go? Right?
right.
Where are they now? And how many are they across the Philippines? Which pockets of barangays, of cities? And that will give us a hint where to deploy most of our resources. So
Like the test kits, right? Because
like the
right,
test kits, like the equipment, the facility, the manpower. If there are volunteers, we would know where to send them out if we know where the people are.
Dr.
So
Dr. Dairit, you talked about Singapore did have some fatalities despite their very efficient management of it. And part of the reason was because they did control the local rate of transmission in their community, but traveling came in. They had one day where they had 47 cases and 33 were brought in, and that was how efficient they were in tracing all of these. I guess in your let me ask Erica's question to you, which is, if we don't have baseline data, how will our government manage this? If you're familiar with the way the Department of Health works, the the people who have lived through SARS. And it seems like, since you mentioned the data, that there are people in our bureaucracy who still have that knowledge. How will we decide on what measures, what data points are being used?
Maria, despite the limitations of our data gathering, we can actually learn from them. And if you look at the data that the Department of Health has released, they have actually indicated where positives have actually been identified. For example, in ARMM, in Bangsamoro Autonomous Region. And that was a result of some of our Muslim brothers there traveling to Malaysia and getting infected. Okay, I was on
Right,
the
right.
I just received a Viber message from the provincial health officer, former provincial health officer of Northern Samar. They've detected the case there. So we know that our provinces are already being seeded by cases. Okay.
Yes.
Our hope is that our local governments are already implementing the type of contact tracing that needs to be done and quarantining of contacts so that the infection doesn't grow there. And so that's really the way they're managing there. But I've made the call to local government officials that I've been able to talk to, that once they see cases appearing in their hospital, it might actually be too late. So they have to understand if the cases that they've seen are firstly imported, in which case they can do the containment measures. That's what happened to Metro Manila. The first 3 or 4 cases were actually imported. But
Right.
after a quiescent period of a month, infection crept in under the radar, and eventually it exploded starting March 5 and 6, because there was already a buildup of those cases in Manila, and it hasn't stopped. And given the backlog in our testing, every day when we announce these new cases, as if they're growing and growing, but that's actually also as a result of the backlog of tests.
Correct.
So we know that the virus is already out there in the provinces, and therefore that's one message that has to go out. Okay, that the virus is there, and they have to do the proper containment so that it doesn't spread.
Correct.
Let me address that issue of when is it going to peak?
Please.
If we're assuming that we're now at 16 to 20,000 today, okay, and if you're assuming doubling times of every 5 days, we're going to reach 75,000 in what? 15 days, right?
Which is what the model stated, actually.
Right, which is what the model stated. And that's when our lockdown period ends,
Yeah.
right?
Correct. Oh my God.
So it just tells us that this is going to go on. And government will have to figure out, what we're going to do at the end of this community quarantine period, given what the numbers are telling us. Now we hope, okay, because the other question is, how do we know that our community quarantine efforts are working, right?
Yes. Yes.
Given that our data is late 7 to 10 days.
Yes.
Therefore, we can only on the road. And we would, the number crunchers are going to have to figure out what were the cases that were occurring before the lockdown period started, and what are the cases after the lockdown period. Those computations only being able to be made after 3 or 4 weeks after the lockdown period. And
Wow.
so I think that's the other thing that's interesting to actually monitor. The ability to monitor what's happening in the lockdown period. So I would say clear the backlog, so that the cases that we're reporting, we know already at least 7 days late, will provide us an even more accurate picture, even if late. Make the projections as a result of that, and then from there, work out the plans.
Mhm.
Because from all in for what it looks like, the cases are still going to go beyond maybe even that surge of 75,000 that was actually predicted by the WHO model.
Wow. Let me ask you just your last thoughts as we wrap up. Thank you for that. It's quite alarming, but very great advice. Erica, your last thoughts.
Yeah, we are now living in this day of age of data, right? We should take advantage of it, really. We should not be afraid of this one. If we want a more objective way of approaching things, we're dealing with a complex system wherein if we do something wrong in one entity, it's going to have some cascading effects. So we really have to look at data. We cannot downplay this and have a more data-driven decision making. So I think that's where that's what I want to push right now.
I guess
And outcomes. Go ahead, Secretary
I'd
Derek.
like my last thoughts to be positive. Okay, one, we've moved on the lab testing issue. We now have more tests being done. I'd like to see the backlog cleared and eventually more testing done in the population.
Yes.
I hope that can be done within the next 2 weeks.
Yes, I hope
Number
so too.
two, I hope that within the next 2 weeks, we're actually able to set up the COVID-19 dedicated hospitals in Metro Manila as well as in the provinces, so that whatever critical cases occur, they can be treated well. Okay. And I guess my third uh, closing remark would be my thoughts for the frontline health workers, that it is imperative that they be given all of the tools and all of the weapons, including the personal protective equipment, to be able to do their job properly so that they're not exposed and eventually die from this disease.
Yeah, I just want to add, correct, to what Sec Dr. Dairit is saying. It's not all grim. In fact, just 2 days ago, we've started working with a team of scientists, both local and abroad, who are working closely with the DOH. So I'm really keeping my fingers crossed. We worked all night last night to build some prototypes, but I cannot announce yet the details because I will leave it up to the government to do that. Yeah, in 2 to 3 weeks, I really, really hope that we will see significant changes with how things are moving.
Fantastic. Thank you both for your thoughts, your analysis, and your positivity in a very difficult time. Thanks again for joining us, and hoping for better days ahead.
Thank you, Maria.
Thank you,
Thank you.
Maria. Thank you, Erica.
Thank you, Sec.